ready to get started. Hello, everyone. Thank you so much for joining us. I'm Olivia Isaac-Sled, Senior Manager of Global Community and Market Development at SATS, part of Ethicon's Robotics and Digital Solutions team at Johnson & Johnson. We are thrilled to host this panel discussion today, moderated by Dr. Marina Kurian on enhancing surgical quality with digital solutions. So please enter your questions and feedback in the Q&A section at the bottom of your screen, and we'll touch on those after the discussion. So I'm honored to introduce our moderator, Dr. Marina Kurian, esteemed surgeon and educator in minimally invasive bariatric surgery. Dr. Kurian is the clinical professor of the Department of Surgery at NYU Grossman School of Medicine. She's president-elect of the American Society for Metabolic and Bariatric Surgery and host for Dr. Radio Show on Sirius XM. Dr. Kurian, we are thrilled to have you and so excited for you to moderate this panel discussion. How are you doing this afternoon?
It's a thrill, really, because I love the purpose of this discussion, and it's to try and increase really surgical quality and how we are able to do that. And what's exciting is this expert panel that we have, and I am thrilled to be a part of this, mainly because I have been working with CSATS for a while now, and it's been wonderful to see what's occurred and how it's changed, really, and how other people rely on it. So I'm really excited to participate. And in order to get started, though, I do want to introduce my colleagues that are on this. And part of the difficulty I'm having right now is actually getting everybody's names up, but I know all of them, and I've been so thrilled to work with them. Sharona Ross is joining us, and she is a professor of surgery in Tampa, and she's doing this despite the hurricane that is going on around her. Welcome, Sharona. She is chief of her division. She's been working with robotics for so long, and it's such a pleasure to have you here. Welcome.
Thank you very much, my dear. It's a pleasure to be here.
Okay, and then we have Dr. Laila Rashidi, who is...
She's ready, just let me
Hold on one second, I'm so sorry. Laila Rashidi, who is in Seattle. I'm sorry about that. And she's been doing robotics for a long time in colorectal surgery, and really is a nationally renowned leader. And thrilled to have her join as well to go through this. And lastly, but not least, is Debby Keller. Debby is also colorectal, and she's been in this space for a long time as well. And her focus has been as well on quality and training. And I just really excited to have all of you on this call together. And part of what we're trying to do is really look at how we're changing surgical quality, which is something that you guys each do on your own every single day, between training not just our residents and medical students, but also by training our teams that we have. So I'd like to hear a little bit from each of you. Perhaps Sharona start. And what I also didn't mention is that Sharona is she's the founder of Women in Surgery annual conference and meeting that I've attended many times, and as likely many of you have attended as well. And she's been such a strong proponent of educating our medical students and our residents, as well as our colleagues, about increasing surgical quality and what the metrics are to do that. And so she is perfect to start, and then let's go to Laila and then Debby.
Well, it is a pleasure to be here among all my friends. And I think that using technology for this kind of technology for education is very important. And I think it's useful. I'm looking forward to the interaction today and to hear what everybody else is thinking about that and what the questions from the audience would be. So looking forward to it.
Laila?
Hi, thank you for having me. It's great to be here with all my great friends and everyone. Well, I think, digital health is important, like Sharona mentioned, definitely for education, for our patient care and how we can do things better. I mean, we have, as surgeons, to some extent, control over what we do and what our capabilities are. But it's through actually the technology and the digital health that we can actually expand on that. And that's where patient outcome-driven factors comes into. So I truly think this is, it's exciting era in our surgical time, and looking forward to see what the future also brings too.
Debby?
Yeah, I agree. And I think that digital health is especially important because it's so engaging. It's visible and it's tangible for trainees, for patients, and even for other surgeons. And it's really boundless at this point, so we can continue to grow.
And, and what I'm super appreciative is how, Ethicon and CSATS have been supporting this. And actually, Ethicon had the vision to incorporate CSATS as a learning platform, and not just for beginners, but for experts as well. And I'll say, I get to work with great people all over the country. One of my dearest friends and also my boss is Christine Wren Fielding, and she recently pointed out how, at first you think, I don't really need anyone to tell me how I'm doing surgery. I don't really need someone to comment on, the steps of my procedure. And she was sort of like, I'm a senior surgeon. I'd be insulted. But then she really saw the value of it because she's actually transitioned to doing robotics. And she saw the value of it and was like, you know what, this is amazing, because now she's looking at it as completely as a senior surgeon, as a method for improving her skills and being able to take constructive criticism while she's, when she's operating and doing procedures. So it really is such a wonderful opportunity for everybody. And her point was really very clear. You guys have always embraced this. I was like, do I really want anyone to do this? No, but it's just nice to see that the value is perceived across the generations, if you will, in surgery. I do know that we have, for our audience, we're really looking forward to all the audience participation, and we will get to your questions at the end. But we have some poll questions, just kind of see where you guys are and what your thoughts are. So we'd love for those of you watching to sort of join in and answer these poll questions. We have two, and we're going to do the first one there.
Okay, so the first, or poll question number one, what do you believe is the most impactful factor that drives surgical quality? And the top answer was A, a primary surgeon's technical skills at 36%. 6% said effectiveness in preoperative planning. And let's see, the third is surgeon judgment. And the fourth was OR team coordination. And none of you have administration support. So we won't tell your administrators that.
I think part of it, sorry, I don't know, I'm being put on mute. I had a tough time with this question because I wanted to say, absolutely, it's surgeon skills that are the most important part. But then I think, and a couple of weeks, I think it was last week actually, was Surgical Tech Week, right? And then probably last month, it was OR Nurse Month or whatever it is. But the truth is, we are all, we have our technical skills, but our OR team is so important to our outcomes, to any delays that we experience during our procedure. What are your thoughts there, Sharona?
Well, surgery is it's a sport. It's a team sport. It's not an individual. I mean, we can be great, but without the support around us, just think about it, without anesthesia, we can't operate really and do majority of what we're doing. So we're completely dependent on the quality of the people around us. And we're supposed to be the glue. We're supposed to be the ones that they would follow and want to do the best they can and to bring their A game to. So I think we are as good as our team is. Skills are good, but it's not enough.
Debby?
Yeah, I absolutely agree with Sharona. And here at Lincoln now, it's the first time I've had a dedicated colorectal team, and it is night and day. They know the procedures, they know the platforms, and we use a lot of robots that are on trial right now for the FDA. So it's amazing for them to be able to know the equipment, to anticipate our moves, and to have everything ready. It makes the day run smoothly, it makes the cases better, and it makes the patient's outcomes better.
You know, and Debby, that's an interesting point you brought up about now just having the colorectal specific team. And what I didn't mention is she's an associate professor of surgery at Mark's Colorectal Surgical Associates in Lankenau, where it's been a strong program for many years. Thank you for that comment. Laila Rashidi, colorectal surgeon and assistant professor at Multi-Health in Tacoma. What about your thoughts? You've been doing robotics from the get-go and have had a great team around you.
Well, I joke with them. I'm like, you guys make me look good. I think it's your team that makes you who you are. Yes, I think surgeon judgment is important. You have to have good judgment to have good outcome. You have to have good skills. But if you don't have the team, like Sharona mentioned, it's a sport. You could be the best player, in that team, right? But if your team is not with you, doesn't matter how good you are. So I think, you definitely need that or support your team with you. And we make each other look good. So I think that's a big factor.
I think one good example was this past weekend in football. If you watch Tom Brady, he's an amazing, incredible quarterback, but he had nobody to throw the ball to. We had so many injuries. It's just, to see Tom Brady runs, it's desperate.
Well, those of you who don't know, Sharona, Dr. Ross is a diehard Tampa Bay Buccaneers fan, so no surprise we brought that up. But Sharona, also, because you're the director of so many things, right? Minimally invasive robotic surgery and surgical endoscopy, and also the GERD and esophageal cancer center, and you're also doing pancreas cancer. It's hard to have so many different teams, right? Like in our institution at NYU, robotics is a big part, and there's a lot of training and cross-training that's going on. And the value of that team is important. Like, when we all did laparoscopy and started out, what was the first thing we all had to know? As a fellow, I knew how to hook up that tower and where the plugs should go, because God forbid you had a problem, you had to know how that works. With robotics, it's a little different. You know what's going under the hood, right? But it is so important and to have different teams as well.
Troubleshooting is really important. And when it comes to training of fellows, I always tell them, you got to be at the bedside first, learn how to troubleshoot. So when you do sit at the console, you know what's wrong. When things are going wrong, what's the problem, how to fix it from the console, but at the bedside. So knowing how to troubleshoot is really important. So laparoscopy is one set of issues, robotics have another, but if you know how to fix them by spending some time at the bedside and realizing how the arms are moving, how the instruments, when something gets stuck, how to resolve that, then you're a better surgeon at the console.
Talking about that, what would you say, and maybe we'll go to Debby, what do you find, especially being at it's not new anymore, Debby, but, at a newer institution, how do you deal with any concerns that you have with surgical quality? Are there personally ways that you try to maintain your team, or do you when you join a practice, you don't want to always do everything differently, right? You want to kind of keep certain elements the same. What is your approach to that?
I think auditing outcomes has always been really important. It was something that kind of ingrained Connor Delaney, who I did fellowship with as a fellow, to look at your own outcomes, look at your group's outcomes, and now look at your own videos. And I think that's critically important, both for the individual cases and for the team dynamics.
Laila?
So,
are you done? I'm sorry, go ahead if you had another.
No, I was going to say, like, no matter which setting you're in, you can always bring that with you.
Laila?
Yeah, I agree. I think, you bring what you have, in each setting as far as your surgical quality. I mean, I'm a true believer that you want to work with your team too. So like right now we're training pretty much all of our nurses, in the OR to know how to run the robot, but at the same time do bedside assisting. So when you bring the group and educate, then, you will, that group is going to come with you and you will count less on, I need this dedicated. As far as the data driven, I completely, I'm with what Debbie said. I'm a very actually data-driven person, collect my own data all the time. And I think it's, looking at your own data, you're looking at your outcome and your own videos. I mean, I started from residency, to kind of see how you're doing things. You learn so much from it and you can actually bring now the group, and work together to, to obtain the best outcome. So I think like we talked about, it's a group work.
I agree. Yes, I agree 100% with Debbie and Laila. And it's definitely everything that they said. Plus, in the past 2 years or so, we've had a lot of challenges with having traveling nurses, and now we currently just getting over the issues that we had with a shortage of anesthesiologists. So it's just been very, very difficult to maintain. I had great teams then. People left to be travelers because they made more money. And so, how can you try to convince them when they can do better for their family, even though they're so good? So it's the training, especially what I do in foregut and HPB, it's a lot of the complex aspects of those specialties. So the teams, I can't request the team member. I want them to want to be there because there's a lot of learning to be done. And a lot of investment that needs to be done from our part. And so I don't want to spend the time and then somebody leaves because it's too much or too heavy or too difficult. And so training the teams takes a long time, but the commitment outside of work and showing them that you really care and appreciative, I think leads to better work ethics and better dedication and commitment on their part. And therefore, they're willing to do the extra work to improve the quality of our patients in the operating room and outcomes postoperatively.
Right. I think I love what you say because it's about engaging them in your outcomes. I mean, the nurses and the scrubs, they know in essence whose cases are coming back, whose are not, but what they don't see are some of the successes because of postoperative care. So when you can bring them in and let them know, hey, we're the best center in Florida, we're the best center in New York or Tacoma or Philly, or in Pennsylvania, it's so great for them to see that and get validated. But now just shifting gears a little bit, what would you guys say to surgeons either just starting out or surgeons switching over to a newer technology or wanting to sort of be like, hey, do I want to do CSATs or do I want to use one of these other, because there are other programs out there as well that do this, that capture your videos and can kind of assess, your progression during your case, et cetera. So how would somebody start out and really sort of embrace it and move forward? Go ahead, Sharona.
I think that it's important not to try to reinvent the wheel. If you especially learn new technology, there are some people that have already done and went through the steps and actually can teach you. And so for me, when I started robotics, I went to see people who did a number of robotic Whipples and literally watched them like a hawk. Every step, I wrote it down. Every instrument, the toolbox, after a year or two that they did those operations, what did they end up with? And my first case was exactly the setup that they did and exactly the step that they took, and then slowly made it my own. So not to feel the need to reinvent the wheel, because then you may make the same mistakes that you can avoid. And so learning from others, I agree with Laila, watching your videos is so important. Like I always feel like, why was it that slow? Because you feel like it's faster than it really is. And so, watching your videos are important. Examining what instruments are you using, because cost is truly important, and that's what drives the hospital. And so if you don't have to have that instruments, try to develop standardize your toolbox. Develop such a toolbox that you absolutely need. Have the others in the room, but don't open them. You can, as soon as you put the instrument into, especially for robotic, into the robot, it's charging. But if it's around, just in case you need it, I think that's important. So in other words, with new technology, try to learn from your colleagues and go to those that are more experts or have some experience, and then develop your own method through those operations and add your experience. For instance, for robotic Whipple, I do first the hepatico-jejunostomy anastomosis, then the pancreatico-jejunostomy anastomosis. People that I went to watch did pancreatico-jejunostomy first anastomosis, followed by hepatico-jejunostomy. So it doesn't matter. It's just a matter of what they use. And so first time I did exactly how they did it, and then made it my own. So I think that's important.
Debby?
Yeah, I totally agree. And standardizing your steps and standardizing and simplifying your back table using like Six Sigma technologies is really important. And also going to the videos after the cases. I think it's easier when you have these standardized steps, because then you can segment your videos so that you're going through step by step. And that way you can grade yourself and grade your progress as you go up the learning curve.
Laila?
Yeah, I agree. I think, when you start, like Sharona mentioned, go see people, watch videos, just see different ways that, it's been done. And then you can develop what you want. And Debbie mentioned, go step by step, collect your data. I would say from the get-go, whatever you do, collect it, because you go back and look at it and see what was right and what was wrong. And to this date, I watch every single of my own videos. And I learned so much. Like Sharona mentioned, sometimes I'm like, oh my God, this is so slow. Or why did I do this? Like sometimes you don't notice. You're in the operating room, you're operating and you're not paying attention, but you learn so much. So when you're in that situation again, you're like, okay, I shouldn't be doing this. This is what I need to be doing. So I think it's really important to, like when I teach residents and fellow, we have steps for each step, of the procedure. This way it doesn't take long, but they actually become expert in that step, and then go to the next step. So I think standardizing, collecting data, watching your video, and be your own judge, right? Judge yourself. Say, okay, what was good and what was bad and what I need to work with. So it's very important, especially when you're starting.
One of the things that when we're talking about CSATs, there's also options. Like one of the big things in social media that really took off initially was when we had the International Bariatric Club, right? Which was where surgeons would pop up videos of stuff that they did. And now we have them through our different societies on either Facebook or on another platform. And I know, Laila, you've been involved with one also that is for surgeons to review other people's videos as well as, looking at yours. Two things that I thought of. One, when you guys were like, you can get better, I was like, I hate watching videos of myself, because I'm like, why did you do that? And I can't come up with an answer, like, why? So, but I think that ongoing practice will be helpful. And because then you can actually inform yourself, like, I'm not sure why I kept touching that. Just touch, like, what were you doing? So that's one thing that you brought up that was great. But now the other thing is really looking at the other options that are out there, like social media. So if you guys either early on or even now watch these videos on other platforms, and what do you get out of it, Debbie?
You get other opinions. It doesn't matter how good you are. You can always be better. And there's someone else that can always do it a different way or teach you a trick or help you to be more efficient, more cost effective. And with that, you get the collaborative effort on social media, on crowdsourcing, on group video-based assessments. And it's invaluable. We wouldn't have it, that open communication across the world otherwise. And some of the platforms, you can even do it in real time when you're learning new technologies, which has been an amazing asset.
And that's great. You're bringing up a different version of this, which is not just improve yourself, but help other people, right? And that's something that, SAGES has certainly been working on. And I'm not sure, Laila, if the colorectal societies are doing it, but, looking at really, it's telehealth in a way, telesurgery. You're there and you can actually look at what's happening. And have other surgeons comment on what you're doing, or teaching like up to 10 other surgeons in some of the different platforms how to do these different procedures.
Very true. And I can't tell you how many times I've learned from fellows who come back from different conferences and said, hey, I've seen where they use this instrument for this. And I was like, wow, that's really interesting. And so anybody, if you can learn one new thing in a day, it's a good day. And so when I learned it from medical students who watch something, what I learned from other videos when I review videos for other conferences, and you're like, oh my God, especially from Asia. Their videos, they come up with great videos, operative videos, and you get ideas. You get ideas about technologies. VBA is incredible. And I think from Advent Health, by the way, is all incorporated with CSATs. And they have shown a great deal of progress among surgeons in their quality of their operations, in the utilization of instruments, just by having somebody review their operations. Although I do have a lot of surgeons that were worried about that, because they feel that can be used against them, that information as well, that you're recording operations, and legally is that going to be somehow hurting them. But it seems to be that it's really not. And so it's all moving toward recording, assessing, learning, advancing, sharing information, all with an effort to help standardize the quality, which should be better quality for our healthcare and our patients.
There's in the General Surgery Times, or General Surgery News, there's an article, I believe, in this past talking about, the viewpoint from the surgeon, the administrator, the legal. And one of the points was for someone who was doing it at the hospital level, every case was recorded, that when it came time for a lawsuit, it was helpful for both the surgeon and the hospital, because it showed that the case went well and that it was, that it actually was an aid. So that certainly is the case. Laila, any other thoughts before we go to our second poll question?
No, to summarize, I think it's great to learn from, others. But second is when you put your videos out there and people kind of give comments about, some of the techniques, or like, what could you do here to do it better? I think that's the most valuable thing, to get those comments. So, and I think that's the beauty of having the social media out and other platforms that we can review each other videos.
Yeah, I absolutely agree. I think, we always joke at our surgical conferences, once they all went to minimally invasive, we're like, where's the video in this talk?
You need it.
Right. You need to see the video, even if it's edited. And the worst is when it's 7x or 9x times and it's really fast. You're kind of a little nauseated, but you still get the point, and you see some really great techniques. And I think that is a lot of how us surgeons learn is visually and watching other people do something. And for me, I'm sort of like, I don't know if I can do that. And then I watch someone do it. I'm like, I can do that. Right? That's
Right.
the key.
You're like, why not? I can do it.
I must say, I liked one time when I heard from Laila when she does the outpatient colectomies, and the whole concept, which I believe to be true, is when you manipulate the small bowel or the colon less than what, like, just some people just keep on touching the bowel and just for no good reason. And when she said that, I was like, that is so true. Why they don't get the ileus. I mean, there are many reasons why they may, but minimize the touch. Touch what you absolutely have to is important. So just, she said it one time and it made me think about it all the time. So it's little things that your colleagues are saying that you never thought of that may affect what you do.
Absolutely. All right. I love, there are already some questions in the Q&A, so you guys keep that up. All of you are watching. We're really thrilled that we're able to share this great information between Dr. Ross, Dr. Keller, and Dr. Rashidi. We do have another poll question, so I'd love you guys to answer this. And if we can put up the poll. Okay, so it is, how do you become aware of new digital technologies to adopt into your practices? Referral from a colleague or a friend, society conference, surgical video libraries, social media, or medical journals. So we'll give people some time. I guess I can vote now too. Okay, we'll give that a few minutes. How about you guys? You guys start thinking about it. I think there's something in here that's not on the list. But let's see the poll answers before we bring that up. Okay, so number 1 is society conference at 40%. Referral from a colleague or friend is then next, 25%. Social media is number 3. Number 4 is surgical video libraries, and medical journals got 0 love. My thought that I when I saw this poll was our reps, our surgical reps that are like, hey, I don't know if you saw this, but I want to, we have this new technology I'd like to show you. And then, you can always, and then they're like, but who's using it is so-and-so, and you can call a friend. What's the name of that show where you can call a friend? Your lifelines. Anyway, but you can get to watch your friends do it, or they show you some videos and you're like, oh, this is actually good. Or you see where you can usually apply it in your own practice. So that's another.
Can't hear you.
You can't hear me?
Yes. No.
Sorry, I think I was muted. So the poll, the number 1 was surgical society. Is that right? Or just pop it back up for a second. Yeah. So what do you guys think about that?
I agree. I mean, I learned a lot from the different conferences, just watching the videos. The video sessions are always very interesting. For me, I think it's reviewing for other conferences, reviewing videos. I learned a lot from that. And like you said, the reps, they'll come to the office or come to the operating room and bring the new technology, and it will be very interesting. Social media is to a lesser extent for me. Medical journals, now we have some that have videos, so you can watch it, but rarely that I would get from that. But I'll read on something, and if I see it's interesting, then I would call a rep or the company to try it. But that's very small percentage.
Debbie?
It's actually surprised with the results. Personally, I learn more from friends and from other surgeons. And I do have reps and companies that will come to me directly. I think that once you are a heavy robotics user or someone who's known to try new technology, people hear that and they come to you. So it's fortunate. I'm also part of an incubator, so I have the benefit of trying things first. And I do learn at conferences. I learn most going to sessions that are outside of colorectal, though. So I would say to people, be open, talk to everyone, go into fields that you don't normally go into, see how you could use something that already exists in your own practice, and don't be afraid to try new things.
Laila?
Yeah, me too. I mean, I had a hard time with this one. I'm like, which one? I mean, I feel I actually learn a lot from social media, just different sites, and people put different videos, or different companies put their product out there. So I kind of learned quite a bit from there. And then definitely the society conferences, like Sharona mentioned, watching the videos or going to the, especially, the sessions, surgeons from Asia, they do a lot of, cool things with new, devices. So and of course, learning from friends or reps. But yeah, I would say the top two for me probably is the society and the social media.
Debbie, your point about, and also actually, Laila, you said the same about going to other societies or other countries, et cetera, because that cross-fertilization is actually so important. Years ago, the first time they used like a clot sucker in endovascular, right? So they were telling me that the technology was actually something to do with cement, that the way that they created that to retrieve the clot had something to do with what they used. And obviously, we don't need to go to industry necessarily, like cement making, but you see that translated for somebody to be like, hey, this is something that we can do in a vessel, right? So it's very intriguing. All right, if we were to put on our crystal ball, and where do you guys think that video-based review will be in terms of impacting either surgical quality or in terms of education? You can pick either, you can pick both in the next 5 to 10 years, because we're really just seeing the nascence of it, and we're starting to see a lot of the benefit. Let's start with Sharona.
Well, I think that if you're referring to machine learning, I really like it for VBA, only because you remove all the bias. There's no gender bias, there's no bias. I mean, because they rely on steps that are accepted to be the correct ones. And therefore, when the machine learning or the AI corrects the steps or review the steps, not corrects the step, but review the steps and score it, it's objective. And so from that perspective, once you have enough machine learning data, then I would really rely on that. Regarding experts, it can be more tricky, but it's very useful. I believe that hearing other people's opinions, especially more experienced ones, it's always good. I think that's where the future is going to be, but more with an objective twist to it, where it really eliminates all the bias.
Laila?
I agree. I think the video-based learning, you want it to be objective of what, you're doing. I think where we're going with that, like Sharona mentioned with the machine learning, it's going to tell you the steps. You know that this is where I need to go. You know that this is the left ureter. Watch out for it. I think what's going to happen is we're going to be in the operating room in the future, and we're going to have the anatomy right in front of us with the steps that needs to be done in an objective manner. As far as, reviewing by other surgeons, I think it's great, especially getting the experience and, their knowledge. But again, it's not standardized to each. So it's still, I learned quite a bit from my colleagues, from my friends, but I think the future is going, like, Sharona mentions, to more objective pattern, and that's what is exciting.
Debbie?
I mean, I think it's just going to have a very prominent role in all stages of surgery. It'll be prospective to help us with case planning, for risk stratification, for prediction of stabs, prediction of complications, just from learning the patterns that we're doing. I think real time is going to help us optimizing the case, the organization, overlays to augment performance during the procedure, and retrospectively afterwards to audit ourselves in collaborative learning.
I would add to that cost. I think that once you standardize those cases, it allows you to minimize do you really need all those instruments? You really need to spend all that time about a specific step when you can do something else. So I think cost is going to be better. It's going to be less.
I mean, the biggest driver of cost is time in the OR, time performing a case, time on the instrumentation. So if we can increase efficiency, auditing results, predicting outcomes, using image guidance during the case, it'll reduce the costs.
Yeah, and also the cost of waste, right? And that's what some of those other, technologies like using black box in the OR, like trying to decrease the waste that goes on and increase the utilization of the actual OR is also so important. And video-based assessment is really coming. I mean, the American Board of Surgery is hoping to use that to, assess our competency. And that definitely is coming. I know SAGES is working on a video-based assessment for foregut. So this is going to come for not just our residents and fellows, but also perhaps us instead, of looking at surgeons in practice and how well they're doing. So those are things that are coming up. Well, anyway, I want
one thing also, sorry, it's besides the cost, it just the predictability. You can predict, like if let's say I'm booking a right colon case, I can say, okay, I'm going to take 1 hour for this. So that can set up, your OR for that day, who's going to come after me. So even in the OR system and in your hospital system, things will become more predictable, by knowing more.
And I'd like to take it to one more step, proctoring and mentoring. Remember, you can broadcast, and there are so many companies now that allows you, like Proximy is one, Theotor is another that will evaluate operative notes and break it down into steps. But being able to proctor from one location to another location instead, I used to have to travel to another hospital, to another state to help somebody. Now I don't need to travel. I can do it from as long as I have a computer in front of me. So there's a lot of technology like that minimize the need to spend time traveling and yet help as many people as you can.
Yeah, this is actually part of all the future and the things that we can do. Absolutely. And not just here, not just proctoring our colleagues, but around the world, like elevating surgery in remote areas. I mean, we have our rural surgeons would say that, hey, we all have our struggles here as well, but around the world, just to be able to elevate that for global health is so significant. Well, anyway, thank you, ladies, so much. This has been amazing. I, am just so thankful to be here and to hear your input on all these different great topics. But we definitely want to hear from our audience, and we are going to shift over to the question and answer. And our host, Olivia, is going to start that process.
Thank you, Dr. Kurian. And thank you so much to all of our panelists. So I think Dr. Rashidi has to leave us a little bit early. So I wanted to just acknowledge her and say thank you so much for joining us. And we'll look forward to having you on board again.
So thanks for having me. I'll be here 5 more minutes. Just had to.
Oh, okay. Super. Well, okay. So we're going to go ahead and get started with the Q&A. So if you have questions, please enter them below. We have had some questions already. So let me get that open. All right. So we started with a comment, and Dr. Keller, I think you're going to just respond to this. And the comment was, fail to prepare, prepare to fail. Always an important adage.
Oh, I agree. I agree that it's a very important point.
Mhm.
And video retrospectively can help you prospectively prepare.
Mhm.
You know, I'll say this is something that we probably all say in the operating room. You know, people go in and when I'm operating, I think of spatially where I am, right? Subconscious, and think of all the things that could go wrong, acknowledging that every case you do is not a same and routine case, that there's something that could come up, and sort of that chance favoring that prepared mind is so important. Like you're like, hey, this just looks a little weird right here. You know, like the time I came across one of the pulmonary arteries, like in a really short person, I was like doing foregut. I was like, oh, okay, hi. You know, I think it's important to really know where you are and to recognize that the probability of something being different can be so high.
No question. With robotic ripples, aberrant blood supply, if you don't know that there is a replaced right hepatic artery coming off the SMA, or sometimes a common hepatic artery coming off the SMA, you're in big trouble because it's right in the line of resection sometimes. So I think it's key to success is being prepared.
Mhm. So we have a comment from one of our audience members who says, at first I felt observed and then motivated to watch carefully my own steps and learn about videos from colleagues that have more experience, not only from robotics, but laparoscopic surgery applied to the most common procedures. So is that something that any of you felt?
Yeah, I think observation is very important. I learned so much just by watching, my faculties. Like sometimes I remember I was a fellow, and as a fellow, you always want to operate. And there was, this faculty that we didn't get to do much, but very skilled and talented. Mm-hmm. And I just by watching, learned so much. And what happens is, what I always tell my residents and fellow, I'm like, you capture from here, and then you make your little pot and you make what you want out of your surgery. So learn as much as you can, just even by watching. And then you bring those pieces, what you like and don't like, and, build your own practice and how you operate. But absolutely, watching is very important.
Great.
There is a purpose for everything that happens in the operating room. For instance, if this is a robotic case and you're standing at the bedside, if you just stand in the bedside and talk to the team and to the scrub tech and you're kind of joking around, you're missing the whole point as to why you're at the bedside. There's so much to learn there. Don't waste your time trying to socialize. Focus on what you need to know. For me, for the complex operations, when I see that you can anticipate the next step, that's when you're ready to sit on the console and actually do the operation. You got to know the operation in order to start operating, right? So being at the bedside is important in the beginning of a fellowship or the few times that you work as a resident with a specific surgeon, so you can sit at a console and be very safe surgeon.
Mm-hmm. Great advice. So we have another question from the audience. How do you use the feedback from the 5 domains and gears from SATS in your clinical practice? Anyone want to address
You track them and you trend them over time. Mm-hmm. I do it for myself. I do it for all of my residents and fellows. You see if there is one of the particular domains that you have issues with, and you make it almost like a report card for yourself. And at the end of each month, we go back through them.
That's great. So this is a really interesting question. So we have someone online who is a student at the Robotics Institute at Carnegie Mellon University. So they say, thank you for a wonderful discussion on improving surgical quality. My question is, what specific field do you envision robotics will help the most in improving surgical quality? Preoperative, postoperative, during surgery, or just overall the entire process?
I think that's really complicated because, right now we're looking at the operative. And I think what informs us as surgeons is certainly our preoperative evaluation of the patient. Mm-hmm. And I think one of our panelists also made mention of looking at the surgical process and then seeing potentially how it affected postoperative outcomes, right? Like you can review your case to see if there was anything wrong or something that could be attributed to it. But it's complicated to say where I don't have a crystal ball for that. How about you, Debbie? You're nodding there.
I actually went to Carnegie Mellon, so much love for this. I think that currently right now we're just using robots like master slave, but they're going to become much more important as we move into the future and increasing efficiency. And there's room for increasing efficiency with pattern recognition and having enough data points to optimize the operation, the post-op care, the preoperative preparation. So there's room in every aspect.
I think that I'll take it to the next level where preoperatively you have something like augmented reality, where you can actually use it to educate the patients, their families, the residents and fellows, and yourself. Or where is the tumor mass in orientation with the major blood vessels, and really define as to what are the risks of the operations, what are the benefits of the operation, why is it a resectable disease, and so all of this is easily explained to the patients, family, residents, fellows, and your colleagues. At the same time, intraoperatively, you can use that same technology to identify, like I said, aberrant blood supply and all. So it will affect that. But at the same time, the machine learning that teaches you how to handle that. So it's important there. And then utilizing what the future is you going to have the steps of experts, right? That end up with the best outcomes post-operatively. So it will affect the post-operative outcomes will affect what you're doing in the operating rooms. And in the operating rooms, you will do based on what you developed in the preoperative setting. So I think it will affect all aspects, and it will truly improve the outcomes because of that. You'll be more planned before surgery, during the operation, less surprise is better. And you have it all set up, and then post-operatively is enjoying the good outcomes and the protocols that you designed.
Mm-hmm. Great. Thank you. So here's another one. Could a video recognize a surgeon's skill limit and suggest training?
I think that in the present, we can use videos now just as part of video-based coaching assessments, going through it with peers, going through it with mentors. So a video itself is going to show you patterns and data points, but someone who does the operation, who knows the operation at a more expert level, can show you the limits that you're currently at and how to exceed them.
Yeah, I agree. I think especially with the machine learning, it will be able to identify those data points, like who's the expert, who's the, naive person or the surgeon who's operating on this, so, and like you said, these are the data points that it will capture, but it comes to a point that we can identify, who's on that console, where are they in their learning curve, and where we need to get to. But for now, I would say what we're reviewing, this video-based learnings and, with more expert surgeons, I would, continue that.
One last thought about the VBA, the fellowship console right now, really trying to encourage people, like let's say a fellow did a case, and that fellow or the attending would suggest, let's go and evaluate this video that we just recorded and go over the steps. And it's like almost an immediate feedback that will allow a fellow and a resident to really learn from the case. And the fellow or the resident can choose that case that they feel they did well or could have learned more from, and then sit one-on-one with a surgeon. So I think the technology allows us to do that, which is very important. Right now.
Thank you. So I think that is all that we have time for right now. I want to thank everyone for your time this afternoon. It was great having you with us. So if you haven't yet joined our global community of surgeons, we do encourage you to sign up, go to csats.com and sign up to access our exclusive surgeon community, where we have over 19,000 procedure case videos and across 10 or more supported specialties. I think we have 11. I got tripped up on that. So Dr. Kurian, Keller, Dr. Rashidi, and Dr. Ross, thank you so much. It has really been such an honor. I'm kind of fangirling over here that we are, we're able to do this webinar with all of you. So you're so highly respected, and really, I thank you so much for your time and your thought leadership on enhancing surgical quality with digital solutions. So again, to our community, thank you all for joining us. The event was recorded, so it will be available for CSATS members. So again, please join at csats.com, or you can scan the QR code on your screen right now to join and come on board as a basic member. And also want to let you know, just to keep your eyes out for our next webinar, which will be in October. So I hope you all have a great afternoon, and until next time.